Hello, everyone. You can start your poll while we're waiting. We're going to give it a few more minutes till everybody logs in, but please feel free to start your poll. It's a total of 6 questions. So if you wouldn't mind, that would be a big help for us. And we'll be starting shortly.
Hello, everyone. Good evening. Welcome to the 2021 Northeast Epilepsy Education Conference. We're so happy to have you join us this evening. As we head into November, which is National Epilepsy Awareness Month, we think that there's no better thing that we could be doing than getting together and continuing our epilepsy education together. It's so important to spread awareness and public knowledge and understanding. So thank you so much for joining us. We have a really great program in store for you this evening. A couple quick housekeeping notes for you. Just so you know, your audio and video will be muted throughout the entirety of the conference this evening, so you can sit back and relax and get comfortable. You'll notice that there is a chat box at the bottom of your screen. Please utilize that to drop in questions as they come to you. You won't be interrupting speakers, so you can feel free to put as many questions in the chat box as you'd like. We'll hold all questions to the end of each speaker's presentation, and we'll do Q&A after each presentation. So please, pop in the chat, drop your questions, or just say hello and let us know you're here. I don't know if I introduced myself. My name's Missy Dalloway. I'm the president and CEO of the Epilepsy Foundation Eastern PA. And again, I'd like to welcome you, and I look forward to a great program with you this evening. So I think one of the first things to address, in talking about epilepsy in general, is that you are not alone. And I think that that's really why we love getting together for situations like an educational conference, as a reminder that you are not alone in your journey with epilepsy. Epilepsy is often thought of as a rare disorder. And so much of that is because, unless you were to have a seizure in front of someone, it's very much so a hidden disorder. There's nothing different about you or any defining features. that, would really identify you as a person living with epilepsy. But as you can see with the statistics on the screen, it's actually quite common. 1 in 10 people will experience a seizure in their lifetime, and 1 in 26 people will be diagnosed with epilepsy. And that's a stat that usually is pretty startling to people because it is, regarded as this rare disorder. But we really think that that's because people don't talk about epilepsy or don't talk about having epilepsy. But that's why we're here. We're here to talk about it. We're here to spread awareness around it and continue our education together around it. And just so you know, in Eastern Pennsylvania alone, there is an estimated 110,000 people living with epilepsy. So you are certainly not alone. And with us at the Epilepsy Foundation Eastern PA, you certainly have friends and advocates alongside you. So a little bit about the Epilepsy Foundation Eastern PA. We are an independent affiliate of the Epilepsy Foundation of America. Our main office is located in Philadelphia, but as you can see with this little map here on the screen, we serve the 18 counties of Eastern Pennsylvania. So our free programs, support services, resources, and referrals, we're providing those all the way up in the Scranton-Wilkes-Barre area, which is where our Northeast Conference first started. Our services go out to the Lancaster area, Lehigh Valley, and everywhere in between. We are a voluntary health agency and a patient advocacy group. And so what that really means is that first and foremost, we are here for you and your families in your journey with epilepsy. We provide a wide range of programs and services for all stages and ages in life and diagnosis. Mary is going to touch on a bit more what different programs and services we offer. But you name it, we pretty much have something for everyone. And we are here for you as your friends and partners in the fight against epilepsy, however we can help you. Before we get too started into our program this evening, I wanted to give a huge shout out and thank you to our generous sponsors who make not only our conferences possible, but so much of the work that we do with the epilepsy community possible. So first and foremost, I wanted to give a huge thank you to our presenting sponsor, Greenwich Biosciences. Greenwich Biosciences sponsored all of our educational conferences and webinars across the board this year. They are really great partners in the fight against epilepsy. And I'd like to invite our friends at Greenwich Biosciences to say a few words.
Thanks, Missy. Can you hear me? Thank you, as always, to the Epilepsy Foundation. We at Greenwich are thrilled to be part of events like this evening. We all joined as one community committed to help put an end to epilepsy someday soon. And Greenwich is certainly dedicated to making that happen. So I just want to say thanks again. And as always, I look forward to a great evening.
Great, thanks, Mike. Next up, I'd like to thank one of our conference series sponsors, ACI. ACI sponsored all 4 of the educational conferences that we hosted in Eastern Pennsylvania this year. I'd love to introduce our friends at ACI to say a few words. You know what? I'm sorry. I don't think that ACI was able to join us. So just giving a huge thanks and shout out to our generous sponsors at ACI. Next up, we have our other conference series sponsor, UCB. Again, UCB sponsored all 4 of our educational conferences across our Pennsylvania series this year. Big thanks to UCB. Would love to introduce our friend Kelly from UCB to say a few words.
Thanks, Missy, and good evening to all the participants of the Northeast Epilepsy Education Conference. My name is Kelly Finnegan, and I work for UCB, where we are inspired by patients and driven by science. UCB is honored to share a few words with support for everyone participating tonight. This not only includes the people living with epilepsy, but all the families and caregivers who stand by you and support you every day. Every day, it is our priority to improve the lives of people living with epilepsy. Together with you, we refuse to let the disease get the best of us, and we will continue to create awareness, wear our purple, spread education, and walk in support of everyone living with epilepsy. Thank you, Missy.
Thanks, Kelly. Last but certainly not least, I wanted to give a huge thank you to our friends at BioCodex. BioCodex has sponsored our Northeast Epilepsy Education Conference this evening. We're so grateful for your support. I'd like to introduce Joan to say a few words on behalf of BioCodex.
Thank you, Missy. It's a pleasure to be here, and thank you so much for including us this evening. I've actually worked with the Epilepsy Foundation for almost 10 years and always feel like it's a privilege and an honor to join these types of programs, especially for education. We are definitely here to help our epilepsy teams help patients. And something I saw on LinkedIn the other day is be the reason someone feels welcomed, seen, heard, valued, loved, and supported, and really truly feel that that is our job every day. So thank you, Missy.
Thank you so much for being here, Joan. And now it is my honor to introduce my dear friend and your Northeast PA Resource Coordinator, Mary Lachlan.
Thank you, Missy, and thank you all of our sponsors. Yes, I am the Northeast Resource Coordinator, and I handle the top 6 counties of Pennsylvania. So to the New York border, to the Jersey border, and down towards Carbon County. So some of the programs that we have, we sponsor recognition and first aid training, and that could be for general public, for families. We also do that for EMTs, for police, first responders, schools, and it's very important, the schools that we do. We do it for the teachers, for the staff, and also for the students, because knowledge is power. And the more that children understand, the less likely they are to bully or make fun of someone, more likely they are to become friends and want to help out. So there's some of our trainings. We have monthly support group meetings, and in my county, but if you're not in my county, there's support meetings throughout all of our areas. We do advocacy efforts. If somebody needs help, they need an advocate to stand by them or help them out, that's what we do. Community awareness events like this, we have different things that we have going on, our walk, our bowling, they're all awareness in the community. Educational conference webinars such like this evening and all across our area. Information and referrals. If someone comes to us and they need to have information about their seizures, what type of seizures they're having, what doctors are available, what services are available to them, we offer that. We have youth, young adult, and adult services. We have programs for them. We try to get people together because it's very isolating to have epilepsy. Sometimes you think you're the only person in the world, and then we get together and we group people, and then they make friends. They realize that we're not in this alone. We have retreats and camp. Pictures there are from our Camp Achieve. It's once a year we have a week-long sleepaway, and it's magical. I can't think of any other word to describe it but magic. The children learn about their epilepsy, but they learn about how to handle it. They see other children with epilepsy, they make friends, and it's just a great experience. So there are some of the things that we do in our area. So tonight's schedule, we've had the introductions. And the first speaker is going to be Dr. Mercuri. Then we're going to have Q&A after that. Then we're going to have Denise Corcoran speak, and we'll have Q&A after that, and then some closing remarks. So without further ado, it's my pleasure and honor to introduce Matthew Mercuri. He's from Geisinger Hospital. He's board certified and a fellowship trained neurologist specializing in diagnosis and treatment of epilepsy. He earned his medical degree from New York University of Medicine. He completed his residency and his fellowship at New York Presbyterian Hospital, Weill Cornell Medical Center. His clinical interests include electroencephalography, and I've tried that all day, and intraoperative neuromonitoring for brain and spine surgery. He's a new dad, and he really is a sharp doctor, and I'm thrilled to know him and introduce him. Take it away, Dr. Mercuri.
All right, thank you, Mary. So I'm going to share my screen here. And you let me know if you guys are able to see this before I get going.
You're good.
How's that? Good?
Yes.
All right, perfect. So again, thank you, Mary and the foundation for the invitation to speak again this year. It's been 2 years since I spoke to this crowd. And during that time, I've had the opportunity to get to know a lot of the members of our local epilepsy community here, and even take on a number as patients. So I just want to say it's an honor to be entrusted with your care. And so tonight we're going to talk about first-time seizure, to treat or not to treat. That is the question. And I chose this topic for tonight because I think if you can understand the rationale for why we treat a first-time seizure or not treat a first-time seizure, then you understand a whole lot about what a seizure is, how we diagnose a seizure, and what the prognosis is for a seizure. I think this topic also highlights some of the unique features of the field of epilepsy, and some of the unique features of the relationship between physician and patient in the field of epilepsy compared to some other fields of medicine. So without further ado, I figured I'd try to make it as cinematic as possible for everyone tonight since we're doing this virtually. Part one of this talk is all about suspicion. So patient comes into the clinic, they're reporting some kind of event or family members reporting some kind of episode. And the question that we have to answer is, did the patient have a seizure? Yes or no? And I wish that the question was so easily answered most of the time. I wish that we could say yes or no definitively, but in reality, the question can be difficult to answer. And it usually takes on one of the following answers. Very likely that the patient had a seizure, likely, probable, possibly, I'm unable to definitively rule it out, and then unlikely. And I call this spectrum the levels of suspicion. And so why is this question even hard to answer at all? And there's a number of reasons. First of all, seizures can have many different appearances, and we call the appearance of a seizure the semiology. That's the symptom of a seizure, that's the patient experiences, and the signs and symptoms that others witness, how the seizure looks. And the semiology is often not specific to seizure. The symptoms that a patient experiences can be due to other causes, even things that are not neurological. So for example, seizures that originate in the mesial temporal lobe of the brain can look a lot like panic attacks. Seizures that originate in the occipital lobe or visual cortex of the brain can mimic migraine aura. Seizures that come from the insula of the brain can mimic gastrointestinal problems. If a patient comes in for evaluation of an alteration of consciousness or an alteration of awareness, there is what we call a broad differential diagnosis for that. Seizure is on that list, but so is low blood pressure, low blood sugar. They might have an infection lurking somewhere. There might be a metabolic derangement. There may be a toxic ingestion at play. Seizures often involve some degree of limb or body shaking. And that could also be due to dysfunction or injury anywhere along the pathway of the brain, the spinal cord, peripheral nerves, and even muscle. Another reason why this question can be hard to answer is unique to epilepsy. It's one of these first things that sort of differentiates this field from other fields, and that is that the patient is often unable to provide their own history. Many seizures do involve a loss or alteration of consciousness or awareness, which affects the ability of the patient to provide their own history. They simply don't recall it, or they don't recall it in enough detail. So we are relying on the observations of other people, if they were present, family, friends, strangers, emergency medical services, etc. But again, a lot of times seizures are unwitnessed. Even when they are witnessed, correctly identifying a seizure as a seizure requires experience due to the nonspecific signs and seizure mimics we just talked about. If you don't have a medical vocabulary, a seizure can sometimes be hard to even describe. Lastly, patients do not always seek immediate medical evaluation after a seizure. And that's sort of a missed opportunity because the emergency room physician can sometimes detect objective signs of seizure on the physical exam. And the lab work that is performed in the emergency department can sometimes show us indicators that a big systemic stressor had just occurred, that a seizure likely happened based on the results of the lab work. So again, there are levels of suspicion. And in order to form the level of suspicion, we must combine the clinical history, what the patient tells me or what others tell me, with the results of our diagnostic testing. So we start with the clinical history. And the first question is the description of the event plausible? Does it make sense for seizure? Does it have the key features of an epileptic seizure? And then beyond that, does this person have any risk factors for having a seizure? So what raises the level of suspicion in the description? Most of these are referring to convulsive seizures, and they're not all or nothing. So these are just supportive. They don't have to be there. Sometimes none of them are there, but these are things that if you hear, they're supportive that it was an actual epileptic convulsion. So tongue biting or other form of self-injury. The tongue bite usually occurs on the side of the tongue, not the tip, and it's usually severe enough to cause a laceration. Eyes are frequently open during a seizure, not closed. There's often bladder or bowel incontinence that is observed. There is sometimes cyanosis. What that means is the patient may turn blue due to dropping oxygen levels during the seizure. The episode must be of a proper duration for seizure. So seizures usually fall somewhere in between 30 seconds and 2 minutes. The majority are under 3 minutes, and rarely do they reach or exceed 5 minutes. Following seizure, there's often a post-ictal state. Ictal just means seizure. So post-ictal state is the state following a seizure, and it's usually characterized by some confusion or some lethargy with a gradual return to baseline. There are also specific respiratory breathing changes after seizure. Oftentimes seems like a person is just in a very deep sleep or they're even snoring. So long inspiration, long expiration phases. They're not breathing fast, rapid, or shallow. And then here are these clinical risk factors that we screen for. So does the patient have a history of a complication during the time that they were, their mother was pregnant? Or did they have a complication surrounding birth or birth trauma? Do they have a history of any developmental delay? Is there a history of head trauma? And we're usually talking severe head trauma, enough to cause a loss of consciousness. Is there a history of infection in the brain or spinal cord, what we would call encephalitis or meningitis? Is there a family history of seizures? Is there a history of a febrile seizure in, well, not only infancy, but earlier in life, which is a risk factor for the development of epilepsy later? And then lastly, is there a coexisting neurodegenerative condition? And what I mean by that, really, practically speaking, is either Alzheimer's or Parkinson's disease, because we do know that both of these conditions are associated with an increased risk of seizure. A quick word on family history. Hereditary means genetically transmitted from parent to offspring, from one generation to another. And generalized epilepsy, that's the kind of epilepsy where the whole brain seizes at once. That's more likely to be hereditary than focal epilepsy, which is the kind of epilepsy where a seizure starts in one area of the brain and then spreads outward. And first-degree relatives are really the ones that confer the most risk. So if you have a first-degree relative with generalized epilepsy, your individual risk for developing epilepsy or seizure rather is 8-fold compared to the general population. If you have a first-degree relative with focal epilepsy, it's 2.5-fold. over the general population. So that's a pretty significant increase in your individual risk based on the presence of a first-degree relative, so someone in your nuclear family. There is a slightly increased risk from a second or third-degree relative, but it's much less. So then what can lower our level of suspicion based on clinical description? Well, sometimes descriptions of shaking that are more like tremors rather than convulsions, low amplitude and alternating from one side to the left, waxing and waning over the course of the episode, thrashing and pelvic thrusting are not usually epileptic. Rolling the body, actually rolling side to side over and over again, is not typically epileptic. Head shaking, like a no-no, side to side, not typically epileptic. Complete preservation of awareness throughout should make you suspicious that maybe this wasn't epileptic. Seizures, although they can be frequent, they're usually not happening multiple times a day for long durations of time. They can cluster, and some patients do have multiple in a day. But if the history is I've had multiple seizures every day for years, that would be atypical. And when the events are exclusively triggered by stressful situations, that makes us think that maybe this could be something more behavioral or something more psychogenic rather than epileptic in origin. So we combine our clinical history with the results of our diagnostic testing. And the three categories of diagnostic testing that we have here for first-time seizure are labs, the EEG, and some form of head imaging, ideally an MRI. The labs, like I mentioned, these are typically drawn in the emergency department immediately following a first-time seizure. And the labs that I'm interested in are the white blood cell count, the lactate or lactic acid, the creatine kinase, and plus or minus a prolactin level. So white blood cell count is a marker of inflammation in the body, very frequently goes up after a seizure and then falls in the coming hours. Lactic acid and creatine kinase are both generated by muscle following any kind of strenuous activity. So following an epileptic convulsion, both of those are usually elevated and again come down over a period of a couple hours. Prolactin is a hormone that can be released during a seizure, although it's not as specific or sensitive as the other three tests. If the patient comes in with a first-time seizure and they also have a fever, or they also have some degree of altered mental status, then a lumbar puncture might be performed to rule out meningitis or encephalitis as a cause for what's going on. And then after labs, we have our head imaging. So this is our MRI. And on the MRI, we are looking for a structural abnormality that is sufficient to cause seizure or to explain why a seizure might have happened. And some examples of things that we're looking for on MRI are tumor, stroke, bleed, scar tissue from a prior head injury. A radiologist would call this gliosis or encephalomalacia. Sometimes abnormalities of blood vessels called vascular malformations can pose focus for seizure. Cortical dysplasia, which is abnormal development of brain cortex embryonically and can cause seizures later. And mesial temporal sclerosis, which is another abnormality in the brain, which can produce seizures, particularly temporal lobe epilepsy, and the list goes on. Not all structural changes confer the same risk of seizure. And then lastly, our EEG. And so on the EEG, we are looking for the electrical evidence of epilepsy. We're looking for indicators in the brainwave activity that this person is at an increased risk of seizure. We call those things epileptiform discharges, and they have many different names: sharps, sharp waves, sharp and slow waves, spikes, spike and wave. But they really all mean the same thing when we're talking about a first-time seizure. And that means that this person, this brain, is predisposed to seizure, and the person likely has an underlying seizure disorder. A quick word about EEG. So EEG is not a very sensitive test. And so when we're talking about the sensitivity of a test, we are talking about the ability of that test to detect the abnormality that it's looking for. So an EEG sometimes fails to detect the electrical evidence of epilepsy in patients who have it. I know this person has epilepsy. They might have even had seizures on EEG in the past, but I could repeat an EEG on them tomorrow and it could come back normal. And that's because the EEG has a mediocre sensitivity. Also, for that reason, a normal EEG does not exclude a diagnosis of seizure or epilepsy. I like to use the fishing analogy for people. If you spend 30 minutes, which is the duration of a routine EEG, if you spend 30 minutes on the water and you don't catch a fish, it doesn't necessarily mean that there are no fish in the pond. It could just mean that you did not spend enough time on the water. So after one routine EEG, we catch about 50% of seizure disorders. After 2 routine EEGs, we catch about 66% of seizure disorders. And after 3 routine EEGs, our number is up to about 80 to 90% detection rate. So the take-home point here is that we can maximize the yield of our EEG by repeating studies or performing long-term EEG recording. That would be an EEG greater than 24 hours to look for evidence of an underlying seizure disorder. And we can do those at home in the form of an ambulatory EEG, or we can do those in the hospital, long-term EEG monitoring. The last thing I want to say about clinical history is when you're obtaining the history from a patient with first-time seizure, it is vitally important to make sure that this is, in fact, the first time. Sometimes people don't realize that they've actually had seizures in the past. And it's not until the questioning that goes on in clinic that jogs their memory, and we realize that this person may have actually had events before, and that changes the management entirely. So for example, if a patient comes in with first-time seizure and they report a history of myoclonic jerks when they wake up in the morning, these are muscle jerks typically affecting the head, neck, and shoulders and upper extremities. Those could be fragments of a generalized epilepsy. If they come in reporting a first-time seizure and they woke up a month earlier with a severe tongue bite, likely that was an unwitnessed convulsion that occurred during sleep. And this patient therefore has actually had more than one event. If they come in reporting spells of staring and unresponsiveness, those could signify focal or absent seizures. Same goes for episodes of lost time. Those could be unwitnessed focal or absent seizures. And sometimes people will report symptoms that suggest epileptic auras. These are focal sensory seizures that don't impair their awareness in any way, that could be happening before the first obvious seizure happens. So if someone comes in reporting a history of powerful recurrent deja vu, the sensation that something has happened before, and maybe it comes along with a phantom taste, like a taste of something metallic or a phantom smell of something burning, that would raise the suspicion for epileptic aura. So the next part of the talk is going to be about classifications. And this is really going to be about terminology, vocabulary, and defining our terms. After we decide that the person's had an epileptic seizure, we have to classify that first-time seizure as either provoked or unprovoked. This can get a little confusing, so I'm going to try to make it as simple as possible. A provoked seizure is a seizure caused by a transient and reversible. So those are the key words, transient and reversible. It's temporary. It comes and goes, and it's fully reversed and goes away. A transient and reversible illness, metabolic derangement, or toxic ingestion. So in a little more detail, what does that mean? A metabolic derangement, we have different electrolytes and ions floating in our bloodstream that sustain life. Sodium, potassium, magnesium, bicarbonate, ammonia, glucose. And if any of these things get really out of whack, either very high or very low, that can pose a significant irritant to the brain and trigger a seizure. That would be a provoked seizure. And then once that level is corrected, once that abnormality is reversed, patient should never have another seizure, right? If this was truly a provoked seizure. Drugs of abuse or abuse potential, including stimulants, usually during the intoxication phase, or depressants, usually after use in the withdrawal period. Those can be provocations for seizure. So examples of stimulants include cocaine and amphetamine, and examples of depressants include alcohol, benzodiazepines, and opiates. Some prescription drugs can lower the seizure threshold and make seizure more likely to occur and can provoke it in somebody who doesn't have epilepsy. Okay, and so some examples of those drugs are tramadol, which is a painkiller, Wellbutrin, which is an antidepressant, and certain antibiotics. There could be another kind of toxic ingestion, either a chemical substance or something naturally occurring in the world, like a plant or mushroom. And lastly, severe systemic infection or critical illness can provoke a seizure, usually by way of metabolic derangement. So that's a provoked seizure, transient and reversible illness, metabolic derangement, or toxic ingestion. Unprovoked is everything else. Okay, so a seizure, it doesn't mean if we find a cause for the seizure, that doesn't mean it's necessarily provoked. Some of these unprovoked seizures, we do find causes, but they're called unprovoked if it's not a transient and reversible illness, metabolic derangement, or toxic congestion. And unprovoked seizures are divided into 3 categories: symptomatic seizure, seizure due to an epilepsy syndrome, and an unidentified seizure. So we're going to walk through each one of those. So a symptomatic seizure refers to a seizure that is caused by a new or an old injury or lesion to the brain. A new injury to the brain is called an acute injury, and an old injury to the brain is called a remote injury. If you have a seizure in response to a new injury, we call that an acute symptomatic seizure. If you have a seizure in response to an old injury, happened 10, 15 years ago, we call that a remote symptomatic seizure. Okay, and this difference is important. And if there's one piece of the terminology that you remember for later, I want you to remember the difference between acute symptomatic seizure from a new injury and a remote symptomatic seizure from an old injury. And when I'm talking about injury, usually we're talking about either a stroke, a traumatic brain injury, which entails usually some form of bleeding into the brain, an infection of the central nervous system like encephalitis or meningitis, a vascular malformation or tumor. Epilepsy syndrome, so seizure due to an epilepsy syndrome. We diagnose epilepsy syndromes based on clinical history, MRI, and EEG findings. This list is not exhaustive. These are just a few epilepsy syndromes out there: childhood absence, benign Rolandic epilepsy, Dravet syndrome, Lennox-Gastaut syndrome, juvenile myoclonic epilepsy or JME, progressive myoclonic epilepsy, and then we have temporal lobe epilepsy, frontal lobe epilepsy, and the list goes on. So if you have a seizure due to an epilepsy syndrome, that's considered an unprovoked seizure. And lastly is unidentified seizure. And this is a first-time seizure with no identifiable cause and a normal neurological evaluation. So exams normal, labs in the emergency room are normal, MRI, EEG, all totally unrevealing. We just have a seizure and that's it. So the final part of this talk is going to be about risk. So when we say to treat or not to treat, what do we mean by treat? We mean start an AED. That stands for anti-epileptic drug. All right. An anti-epileptic drug does not fully eliminate the risk of seizure, but it does significantly reduce it. There are many options to choose from, all with unique pros and cons. This graph on the side is a little out of date. It doesn't have all of the drugs we actually have at our disposal today, but over the last 110 years or so, you can see that there was a sort of explosion of drug development in the 80s, 90s, and early 2000s. The last one here is Aptium, esifarbazepine in 2009. But even since then, we've had the addition of Briviact, Epidiolex, and most recently cenobamate, which is Xcopri. Every drug has a different pro or con, different side effect profile. Everybody responds to medications differently. The decision to treat with an AED after a first-time seizure is based on an assessment of risk. And there's 3 types of risk that factor into that decision. Risk number 1, what is the risk of having another seizure? The probability, the likelihood, the odds of another seizure. We call that the risk of recurrence. What is the risk of having another seizure in terms of the consequence for the patient? What are going to be the repercussions of another seizure in that person's life? And lastly, we have to talk about the risk of starting an anti-epileptic drug. And what we're really talking about is the potential for side effect. So we'll start with risk number 1, which is the probability of having another seizure. Why is there any debate about this at all? Well, the conventional teaching and medical training is don't treat a first-time seizure because, like Missy said at the beginning of this, 1 in 10 people, 10% of the population will have a seizure at some point in their lives. And a minority of them, so less than 50%, will go on to have more. In other words, wait for the second one to happen. That's sort of what gets drilled into your head in medical training, but in reality, the management is much more delicate and complicated than this. And time is not our only diagnostic tool. The same tests that we use to raise or lower our level of suspicion for seizure, those are the same tests that we use to determine or stratify the risk of a seizure recurrence. MRI, we're looking for a structural abnormality that's adequate to cause a seizure. If present, it stands to reason that that person's going to have a higher risk of recurrence because there's an abnormality on the MRI that can potentially cause another one: tumor, stroke, bleed, scar tissue, etc. And EEG. If there are epileptiform discharges, if there's spike and wave on the EEG, well, that indicates that this person likely has an underlying seizure disorder. So if they've had one seizure, they're going to be high risk for having another one. There have been multiple population studies over the last 40 years looking at the probability of having that second seizure. The landmark study was performed in 1982 by Hauser and colleagues. They had 244 patients with a first-time unprovoked seizure, and they found risk of recurrence of 16% 1 year out, 21% 2 years out, and up to 27% 2.5 years out. They then did what's called a subgroup analysis, where they took those patients with first-time seizure, and they found that if they had an abnormality on the EEG, right, if there was spike and wave on the EEG, then they were actually at a 50% risk of having a seizure in the next 18 months, which is pretty high. If they had an abnormality on the MRI, what we would call a remote symptomatic seizure from an old brain injury or lesion, they had a recurrence rate of 34% at 2 years. It's also worth noting that the majority of patients in this study were treated with an AED after their first-time seizure, and they still recurred. So the recurrence rates are probably higher if left untreated. This same group of people got together again in 1990. They did another study with 208 patients and found similar data. The risk of recurrence was 29% 3 years out and 34% 5 years out. If there was an abnormality on the MRI, the recurrence rate again was close to 50%. This one they were looking at 5 years out. We had the first trial in 1993, the first seizure trial. They looked at 397 patients and they divided them into two groups: treat or not treat. Okay, the treated group, they had a second, 25% of them had a second seizure at the 2-year follow-up. The untreated group, double that, 51% of those had a second seizure at the 2-year follow-up. So the conclusion was treating after a first-time seizure reduces the risk of recurrence. We know it reduces it at 2 years and probably reduces it beyond that, but 2 years was the only, that was the duration of this particular study. The European Multi-Center Epilepsy and Single Seizure Study, also known as MESS, in 2005, looked at a larger group of patients, close to 2,000, and long story short, they found similar numbers. Patients with first-time seizure who were treated had recurrence rates of 32% at 2 years and 42% at 5 years. Those who were not treated had 39% recurrence at 2 years and 51% recurrence at 5 years. This is an important study, a little different from those others that we just talked about. Hesdorfer and colleagues in 2009, they looked at those acute symptomatic seizures compared to remote symptomatic seizures. So remember, these are the ones I wanted you to remember. A seizure that's due to a new brain injury or new brain lesion versus a seizure that's due to an old brain injury or old brain lesion. They found that over a 10-year period, patients who had acute symptomatic seizures were far less likely to go on and have another one compared to those with remote symptomatic seizure. In other words, if a patient comes in with an acute stroke or an acute bleed and they have a seizure a day later, 5 days later, 7 days later, that person is less likely to develop epilepsy than a person who comes in with a first-time seizure 5 years after their stroke or 10 years after that stroke. And the reason is in the remote symptomatic group, the brain has rewired following the injury in a way that is prone to seizure, right? Whereas in the acute group, that injury still has a chance to go away and to heal, and it's too early to know whether they're going to go on to have any more seizures. But if they're coming in with a seizure from an old injury, the risk is much higher that they're going to continue to have seizures. And this is a graph just showing that. The green line is the risk for those who had an old lesion on the MRI, and the red line is the risk over time for those who had a new lesion on the MRI. The best data, and this is the last slide of numbers I'm going to throw at you, the best data that we have on recurrence risk comes from the 2015 American Academy of Neurology Practice Parameter on the management of first-time seizure. And this is such an important study because they looked at hundreds of articles and hundreds of studies, 281, and they compiled all that data. And they determined, based on all of this prior work, that the likelihood of having a second seizure in the 2 years following the first time unprovoked seizure is somewhere between 21 to 45% on average. Okay. And the most significant predictor of having another seizure is an MRI showing an old lesion, an old injury, so those remote symptomatic seizures, or an EEG showing epileptiform discharges. The third take-home point from the practice parameter is that starting an anti-epileptic drug after the first time seizure reduces the risk of a second one by 35% over the next 2 years. But this is important, waiting until the second seizure to treat, the patient's not going to be worse off for that in the long run. Delaying therapy until a second seizure did not influence the chance of long-term remission. So if the patient was started on anti-seizure medication after seizure number 1, or they were started on it after seizure number 2, those people had an equal shot at becoming seizure-free. The only difference is that patient number 2 had a second seizure, and patient number 1 did not. So to summarize risk of recurrence, we know that the 2-year risk of recurrence is somewhere between 21 to 45%. This is the number that I actually cite people in clinic. But we can get a better idea of an individual's unique risk by obtaining the following: good clinical history, MRI, and EEG. History, we're looking for birth trauma, developmental delay, history of head trauma, infection of the brain or spinal cord, family history of seizure, Alzheimer's disease or Parkinson's. MRI, we're looking for an abnormality sufficient to explain seizure, either a new lesion or injury, which would be acute, or an old lesion or injury, which would be remote. And EEG, we're looking for epileptiform discharge, also known as spike and wave. And this is my categories that I put patients into. So this is not validated, but this is the way that I think about it. High risk, I think you're high risk if you have an EEG showing spike and wave and or an MRI with an old lesion, okay? And this is based on all that data we just looked at. We know that you are high risk, going to be greater than 60% in the long run for having another seizure if you have an EEG with spike and wave or an MRI with an old brain lesion. You're medium risk if you have an MRI brain with a new lesion or injury, or you have risk factors in your clinical history that suggest that you might have some epilepsy risk factors, you might be at increased risk. You're low risk if you have a completely normal workup. First time seizure, normal workup. Those are the unidentified seizures. The high risk group, I say treat almost always. It's like 99.9% of the time I'm going to treat that person who falls in the high risk category. Medium risk, I'll say we treat sometimes. And I put an asterisk here and said short term next to those with a new lesion or injury, because if a person comes in with a new lesion or injury, like a new stroke or a new bleed, and they have a seizure in the setting of that or due to that, we know from the data we just looked at that they're not very high risk to develop epilepsy. But in that short-term period, right when things are hot and the brain is aggravated from the stroke or the bleed, it makes sense to put them on some kind of anti-seizure medication in the short term. So that's frequently done. And then the low risk group we treat rarely. And the risk of recurrence is the most important factor when deciding whether to treat a first-time seizure. But it is not the only factor when deciding to treat, particularly when we're in medium risk or low risk categories. So the other factors to consider, I call this the risk triangle. We have two other important factors to consider. We have at the top the probability of having another seizure, which we've just gone through in detail. But we also have those other two forms of risk, the consequences for the patient of having a second seizure, and the side effects of AED therapy if we start a drug. So what could be some consequences of having a second seizure that might make somebody want to go on anti-seizure medication, even if they are in the low risk, or even if they are in the low to medium risk? So obviously, there's the potential for harm to self or others in the event of another seizure, depending on what they're doing at the time or where they are. There's the impact on driving privilege, which I'm sure many of you are familiar with. Every state has a different law pertaining to it. In the state of Pennsylvania, it's a 6-month driving suspension after seizure. you need to be seizure-free for 6 months on or off anti-seizure medication in order to drive in the state of Pennsylvania. There can be an impact on employment. You might not be able to continue doing the thing that you're doing safely. Your employer might not be able to make reasonable accommodation if another one happens. And then that can have an impact on financial security, the ability to provide for one's family. There can be an impact on lifestyle and recreation. So I have patients who like to ride horseback, patients who like to fish and spend time out in a boat on a body of water, patients who like to go hiking, and spend a lot of time at heights. Those are people who say, look, I know I've only had one seizure. Maybe I'm in the low risk or moderate risk, but I want to go on anti-epileptic therapy because the risk of having another one, the consequence of another one is too great for me. And the last thing I put in this list, I put an asterisk next to it because it could be a talk unto itself. But pregnancy is a very unique situation for first-time seizure, where the consequences of having a second one could be devastating for the mother, for the baby. And so that often changes the calculus on whether to treat or not, particularly if they're in that low risk category. And then on the flip side of the coin, we have to consider the side effects for drug therapy. Not all medications are going to produce a side effect. In fact, the majority of people don't experience a side effect to a single anti-seizure medication. But among those most commonly reported are fatigue, cognitive slowing, dizziness, nausea, and mood changes. And so the potential for those side effects and the effect that can have on a patient's quality of life sometimes makes someone opt to not go on anti-seizure medication, even if they're in the medium or sometimes even high risk categories after first-time seizure. This becomes particularly noticeable in patients with terminal conditions, so later stages of cancer or later stages of dementia, where the top priority is maintaining a good quality of life in the time that the patient has. And so although there might be a risk of seizure in 2 years or 3 years or 5 years down the line, the priority is preserving the quality of life every day. And if they're going to feel fatigued or slow or dizzy on medication, then in those cases, we often opt for not starting medication after the first time seizure. And so this is, I think, where another one of these areas where the relationship between the doctor and the patient is different in epilepsy compared to some other fields because of the nature of what we're talking about and how personal and intimate a lot of this is, and how much there really is to talk about and explain. And I think really what we're doing is we're gauging the personal beliefs and biases of the patient and of the doctor, and we're doing some shared risk taking together, which is not common to all fields of medicine, doing something like shared risk taking to decide on whether to treat or not. But it makes it a very fulfilling and an engaging topic, and I think that it's one of the good things about epilepsy is that we're able to have this discourse with our patients. So in conclusion, did the patient have a seizure is not always an easy question to answer. First-time seizure must be classified as either provoked or unprovoked, because we don't treat a single provoked seizure. We're only interested in the unprovoked. Unprovoked seizures include remote symptomatic seizures, seizures due to an epilepsy syndrome, and seizures with a normal workup. A physician uses details from the clinical history and the results of diagnostic testing to determine the risk of recurrence. The decision of whether to treat a first-time unprovoked seizure is based not only on the risk of recurrence, but also the consequences for the patient of having another seizure and the potential side effects of drug therapy. And last, the patient's personal beliefs and values play an important role in the decision-making process, and this is what I call shared risk-taking. So with that, I will conclude. I thank you for your attention, and I'm happy to field any questions you might have.
Okay, well, thank you, doctor. That was really interesting. I learned a lot from that. I have a few questions here. People want to know, can you grow out of seizures? Is it possible?
Yes. So if you are diagnosed with a seizure disorder, meaning you've had multiple seizures The definition being 2 or more unprovoked seizures. So you have a seizure disorder, there is the possibility to outgrow a seizure disorder. It's more common in children. It's more common in pediatric epilepsy syndromes to outgrow it over time. It's less common for adult onset seizures to be outgrown. But it does happen sometimes, and there is a term called epilepsy remission. And it's a high bar to meet, but epilepsy remission is 10 years of seizure freedom, 5 of which are off all anti-seizure medication. So if you're 10 years seizure free and 5 of those are off meds, then you technically meet the definition for epilepsy remission. So it is possible, more frequently in pediatric cases.
Okay, thank you. Someone wanted to know if you could tell them if there's a specific cause to nocturnal seizures, where you only have them in your sleep.
Yeah, so it's actually pretty common for seizures to occur exclusively in sleep. We know from looking at EEG that when a patient goes to sleep, that's when a lot of the abnormalities crop out. You might have had the experience of having your neurologist tell you to sleep deprive before your EEG. And the reason for that is sleep deprivation is irritating for the brain, for the cortex of the brain. And it makes epileptiform abnormalities more likely to appear on an EEG. And we see them when the patient does fall asleep during their EEG. Stage 2 sleep in particular is highly epileptogenic. The reasons for that are not exactly known, but sleep is a highly seizure-prone time across the board, regardless of seizure type. Generalized epilepsy, that's the type of epilepsy where seizures, the brain turns on and off in unison with the seizure. Those frequently are nocturnal. In fact, a history of nocturnal seizures is, I didn't put it on the slide, but it's one of them that can raise the level of suspicion that what we're dealing with here is actually epileptic, because it's happening exclusively at night, because it is such a seizure-prone time. I hope that answered the question.
It did. It was very good. Someone asked, they had a stroke as a baby. They're now 53. What category would they be in? They're controlled with medication.
Right. So, yep. So stroke in the past. So what we have here is a situation where there's an underlying structural abnormality from the past that's causing seizures in the present or years down the road. So that is a symptomatic epilepsy, a symptomatic seizure. It would be remote symptomatic because it's related to an old injury to the brain.
Okay. Now, someone said, could you elaborate on strokes, on how you can tell the difference between a stroke and a seizure?
Of course. Right. So stroke would have been something we could have mentioned on that page about seizure mimics. Stroke can mimic seizure. Seizure can mimic stroke, particularly focal seizures that are beginning in one area of the brain. Because when a patient has a stroke, what's essentially happening is an area of the brain is losing its blood flow. It's losing its blood supply. So that area can no longer function. And the symptoms that the patient is having in their stroke is due to the loss of blood flow to that particular area of the brain. So if it's the language center of the brain, they won't be able to speak during the stroke. If it's the visual cortex of the brain, they'll lose part of their visual field. When a patient has a seizure, that area of the brain is not losing its blood flow, but it's still being taken over by a different process. It's being taken over and it can't perform its normal function. So for that reason, a seizure that starts in the language cortex can look just like a stroke that's happening in the language cortex with an inability to speak. And the only way that we can differentiate these things is by observing the patient, seeing the time course, you know, as the seconds and minutes and hours unfold, and most importantly, obtaining emergency imaging to actually see whether a stroke is happening, because we can visualize the stroke on CT scan and on MRI, whereas a seizure will not have any of that evidence on the imaging. So that's how we differentiate the two.
Good. What are the long-term risks of anti-epileptic drugs, particularly the earlier types of medications?
Right. So the older generation of anti-seizure drugs generally have more long-term side effects than the newer generation of seizure drugs. So I think what drugs that they're probably referring to or kind of from that era are things like phenobarbital, Dilantin, Depakote, Primidone, Tegretol. These are great medications. They're very effective. We still use them frequently today, even with our newer generation medications. But they do have more of a long-term side effect profile. Particularly, we have to watch blood counts over time. We have to watch liver function over time. There's a potential for liver toxicity. And bone demineralization. So there can be accelerated bone loss, early osteoporosis from long-term use of some of those older medications. There's a long list of potential side effects for all of them, but the main ones for those are going to be bone loss and just watching blood counts, liver function, things like that.
Okay. What could puberty play in epilepsy? What role does that play?
So there's definitely an association between seizures and hormones. It's well established, and we see it in multiple different ways. So for instance, when a patient becomes pregnant and they have all those hormonal changes that occur during pregnancy, sometimes people's epilepsy gets worse during that time frame, sometimes it gets better. Same when patients go through menopause, same thing can happen. You can have an improvement or a worsening. There is catamenial epilepsy, which is epilepsy that worsens specifically during a menstrual cycle, and has a term, catamenial epilepsy, and it's due to the hormonal shifts. So puberty is one of these times where there's a lot of hormonal changes happening, and it's possible that those hormonal changes during those early teenage years provide some of the trigger for why the epilepsies present at that age and not later on or before then. So I wouldn't say that it's the cause of an epilepsy syndrome, but it could be the thing that unmasked it or brought it to happen in that moment is because of the hormonal changes.
Okay. Someone asked if they've had 2 resections and are currently on 2 seizure meds and are still seizing. What are the chances of ever coming off seizure meds, or will the meds be lifelong?
Hard to answer the question without knowing more details about this particular individual's case. So I don't want to speak on it and say one thing or the other without really knowing all the details. But what I can say, in generally speaking, is that if epilepsy fails to respond to multiple medications, the likelihood of it responding to additional subsequent medications decreases. So if it doesn't respond to a third, it's less likely to respond to a fourth, and then to a fifth, to a sixth, to a seventh, et cetera. And it's in those cases where we look to options like epilepsy surgery, either resecting the epileptic focus or putting in a stimulator to try to treat the epilepsy, such as a vagus nerve stimulator or a neuropace responsive nerve stimulator. That's called neuromodulation. When patients have implanted stimulators, that sometimes, if they're working and they're treating the seizures, that gives us an opportunity to reduce medication. But it is not common to get someone off completely, even in those cases. There's usually some amount that still needs to be on board to preserve seizure freedom or good seizure control.
Okay, and the last question we have, if you get brain surgery, do seizures stop for good, or do you still have seizures?
Right. I assume you're talking about resective brain surgery specifically for epilepsy. And so it really comes down to the type of epilepsy that the surgery is being performed for. So we have good data for something like temporal lobe epilepsy in the non-dominant hemisphere. We know that if we do anterior temporal lobectomies in these patients, they have a seizure freedom rate or a cure rate of around 70%. But if we have a frontal lobe epilepsy, we know that their success rates are much lower due to the nature of frontal lobe epilepsy. So it really all boils down to what type of epilepsy that person has, where in the brain it's coming from, and what treatments have been tried for it to this point to really answer that question.
Okay. Okay. Someone did raise their hand, but if you can put it into chat, because we can't open the microphone. So if you have a question, just type it into chat if possible. And otherwise, thank you, Dr. Mercuri. It was wonderful. It's always good to hear you. And we're going to move on to our next speaker.
Thank you, Mary.
Thanks again. Okay, now our next speaker is Denise Corcoran. She is Executive Director of ARCIL, Anthracite Region Center for Independent Living, since February of 2007. She has a Bachelor of Science degree in elementary education from Pennsylvania State University and a master's degree in organizational management from Misericordia University. She is a human service board certified practitioner and has been a social worker in Hazleton for over 30 years. Denise, you must have started as a child, but we will turn this over to you now, and thank you.
Well, thank you, Mary. Yeah, it's hard to believe how long I've been a social worker at this point, but it's always been fun, so it's a good thing. First, I just really want to thank, well, first I want to say, Dr. Mercuri, your presentation was amazing. I learned so much, and it was just very interesting, so thank you to him on his presentation. And also thank you to the Epilepsy Foundation for asking me to speak. When Mary and I had talked about this months ago, it was planned to be in person. And so we had talked a little bit earlier, we really wish it was in person, and we miss seeing people and chatting with people in person. But unfortunately, as we all know, this is where we're at. So, you know, today we're doing Zoom, and that's what we have gotten used to, sort of. Still may mess up things on Zoom. But a little bit about the, I'm the director at the Anthracite Region Center for Independent Living. That's our official full name. But for the rest of the night, I'm going to call it ARCIL. Many of you have worked with social service agencies and government entities, we use an awful lot of acronyms. So I'm going to try really hard not to use them tonight. I may use them after I say what they are and what they stand for. So if I say an acronym, you don't know what it is, please throw it in the chat and I'll let you know what it is. I'm sorry, there's a plane going over the house right now. Okay, I'm not sure if you could hear that or not, but there is at least one Center for Independent Living in every state in the United States. It's a mandate from the federal government that there must be at least one. Pennsylvania has 17 centers. We are located our main office is located in downtown Hazleton, and so it's in Luzerne County, and the services we provide are in Luzerne, Schuylkill, and Carbon County. Just to give you an idea of where we work at. We, as a Center for Independent Living, we help people with disabilities of all ages, all types of disabilities, and we also have no income. So I know sometimes for programs there's income verification and you have to meet a certain income. We do, or below a certain income, we do not have that. We do not ask for income verification for our programs. Some programs we work with, there is other programs from other agencies, but not with ours. We also do not need proof of a disability. Someone comes and says to us, I have a disability and I want some help with services. That's all we need to be able to start giving those services. Our mission is that we are to enable people with disabilities to live as independently as possible. And so that could be whatever someone's level of independence is. It could be living completely on your own, it could be living with family, it could be living in a group home, whatever your level of independence is. Something I always like to say is that nobody lives independently. We all depend on other people in our everyday lives. I do live on my own, and I have one of my coworkers is on tonight. She will laugh that, you know, I'm not a plumber. So when something happens with my plumbing, I need to know who to go to. I'm not going to say, oh, I have no heat, I'm going to fix it because I live independently. No, I'm going to call a plumber. So, you know, you need to know who, and we all need to have help from others to be able to live independently. But we just look at someone and say, you know, how do you want to live? How can you accomplish that? We meet with our consumers on a one-to-one basis. Things have changed a bit right now during the pandemic. We are not working in the office, and all of our appointments are, everybody we see now is appointment only, and we are working hybrid, but we are returning phone calls and doing webinars and doing Zoom like this, and all different ways of meeting with consumers and meeting face to face with the consumer if the consumer is comfortable with meeting with a staff person. We would never put someone into a situation that they would not want to be. We treat everyone as an individual. It's the number one thing that we do with all of our consumers. Our staff is comprised of, we have 7 full-time staff and we have 6 part-time staff. And most of our staff have been working at the agency for several years. And so we have a system in place of making sure that consumers get the best help and the best person to work with them when they need our services. Something about the Centers for Independent Living, and I said that there's one in each state. Every single Center for Independent Living must provide the 4 core services. Those 4 core services are information and referral, advocacy, peer support, and skills training. Information and referral services are when someone would contact our office. Either they send us an email, a text, they call the office, and they say that they need they have a question about something, and we give them advice. It could be something as simple as someone calls the office and says, I need the number for the Epilepsy Foundation. And we have a list of all the different agencies. We look it up, we give them the number, and then that's it. We never hear from them again. It could be someone who needs our services. And so then we would start working with them and seeing what services they need, again, to live independently. We do advocacy. We help people who run into barriers because of their disability, whether it is an inaccessibility or a discrimination. We work with businesses to help them to become more accessible. We may get a call from someone who's having an issue at their employment where they need to have some devices that would make their job easier for their disability, such as a larger computer screen. And so they're able to do the job, and then we need to hook them up with another agency that would be able to help them with purchasing a larger computer. Or a lot of times the businesses, they will take care of them that themselves. We do peer support. We provide peer support for consumers. A person with a disability who is living independently works with another consumer to help them make adjustments to live with their disability, to learn problem-solving skills, explore options, and use community services more effectively. Someone who has a disability is able to help out someone with a disability and be able to help them with their own disability because they have the same shared experiences. And we also have skills training, which is where we help our consumers with, again, skills that they can use to live more independently, such as budgeting, preparing meals, shopping, using transportation, finding employment, job skills, job interviews, writing a resume, how to interview for a job, and writing out checks, how to balance checks, all of those to help somebody, again, live independently. There's also, you may hear talk of a 5th core service that's kind of it's called transition. And a little bit about SILs too. There's 2 types of SILs. There's the state funded SILs, and then there's a federally funded SILs. ARCIL is a state funded SIL. We receive our funding from the state of Pennsylvania. So transition is not officially a 5th core service. For the federal SILs, it is. And transition has also, we've been doing transition, so we kind of have been providing that service. And transition sort of falls under 2 different transition. One is transition for youth, to go to what they want to do after graduating from high school, if they're looking at going into college, if they're looking at jobs, job skills transitioning, if they're looking to moving into a home of their own from their parents transitioning. And then there's also the nursing home transition. And that would be for someone who's in a nursing home, but wants to return back home to their community. And there's also Centers for Independent Living that work with nursing home transition. So if someone would call our office and they're looking to move out of, we do not per se provide that. We would assist them, but we would have them contact the SIL that would, in our area, that would help them with transitioning out of a nursing home. Like all other CILs, we provide other services. We manage the Wheels on Wheels accessible transportation. We have 5 accessible vans. These vans are not medical transportation, so we are able to take consumers to places that they would otherwise not be able to go to, because a lot of times transportation is only for medical. It's a door to door. Many of our consumers who use our vans, they use them for jobs, for education purposes, for entertainment. They like to go to concerts, they like to go to the movies, socializing, going out and shopping. We've had consumers who've only used our vans for a short period of time. They've had an injury, broke a leg, broke an arm. Due to that, weren't able to work, but their job, they are able to work. They're just not able to drive. So they need a ride to get to and from work. So we would provide transportation. Our vans run pretty frequently during the most days of the week. They usually are during the day's work hours, but if someone's going to an event at night, or we do try to, as long as we have enough time frame to try to get somebody to be able to take them to an event, a concert, or an activity at night. The vans are fee for service, so they are based on the mileage of the trip. Our vans are registered with PUC, and so we follow the Pennsylvania Utility Commission's guidelines for our vans. And we also recently were certified through the Office of Developmental Programs to run vans for consumers of the ODP waiver. The things that we now talk about that we didn't talk about 2 years ago, our vans do follow all of the CDC guidelines, by meaning that we have frequent cleaning. Riders need to have their temperatures taken. They have to wear masks. Our vans only, I think our largest van only has 6 passengers at a time, but now only 2 people can be on it from the same home. So where before we could have people from different addresses, now we can't do that. And we also they must have masks on their vans. And so again, CDC guidelines, that we do follow all of those. Our transition for our youth and our transition for our youth and our consumers, we oftentimes work with the Office of Vocational Rehabilitation. So that's now OVR. So I'll be throwing that acronym out. We had been working with their pre-employment transition services program, and we've been very active with that, going into the schools and providing education to students with disabilities on living independent living, being advocates, the whole independence, where that came from, the ADA came from. Again, unfortunately, with the pandemic, with schools not being open, we have not been able to do that. And even now, the schools are open, but they're limited as who they want to come into their buildings, which we understand. So hopefully we'll be starting up with that again. We do work with OVR frequently. If somebody is looking again to go work, they would help train and help them with employment skills. And so we do work a lot with our OVR office. I'm just gonna make notes. We do work with nursing homes. If we do get a call from someone that's in a nursing home, to give them the ombudsman number and helping them to find out what they would need to do to return back home. And we have also at our agency, we have several support groups. We have a DAC group, which is our Disability Action Club. The group meets and discusses different accessibility issues and works on strategies to have the issues resolved. An example of that would be you go to a restaurant and the bathrooms aren't accessible. And so what we usually tell our consumers when we tell people with disabilities is, you're your best advocate. Go to someone at the restaurant and say, we really like this restaurant. However, the bathroom isn't accessible. And sometimes it could be something as easy as moving the garbage can. Places will put the garbage can under the sink. The sink is open underneath, so someone who's using a wheelchair is able to use the sink. They're not thinking that. They put the garbage can under there because it's convenient. So sometimes it's something as easy as just moving a garbage can. So we do that and tell them to, talk to the management or talk to someone at the restaurant or store or someplace that's not accessible. The DAC groups then will meet if they've tried doing that and to no success they'll talk with the other members. What should we do? How do we go about? Should we go there as a group? Should we write a letter? what's the best way to try to get places accessible. It originally started out, we had a program with the Hazleton Area School District. It was a VITAL program. And that was an actual house that we had where students went to and they learned skills. They learned how to meal prep. They made a shopping list. There was a bank account. They wrote their own checks. They learned transportation. It was actually located in downtown Hazleton. They learned how to take public transportation, go to the library. They would come to our office and meet with our staff. And so our DAC group actually came out of the graduates of that program. And they just have really wanted to stay together. And so we've kept them together. And actually, I'm wrong on that. That's our life group. Our DAC group is for our older. Our life group came out of our VITAL program. Our life group is our younger adults. And life stands for living independently for everyone. Again, we're big on acronyms. So that's what our life group is. They came out of our VITAL program, excuse me, and they've stayed together, and they also work great as a support group, helping each other with employment. If someone might work at the local supermarket and they'll say to their friends in the life group, hey, we're hiring, you should put an application in, I'll mention your name, and help out with trying to get them employed or helping them with other issues. The group really discusses issues that are happening and that needs for them right then, or that they're going through. We've had speakers come in on domestic violence, on trying to think of some of the other, on healthy meals, on different STDs, dating, what it's like to date with a disability, just all different programs of, and they make the decisions on what they want somebody to come and speak to their group about. And so they're a very active group. Again, the pandemic has we used to meet in person, now we're meeting via Zoom. But we have kept that going. And during COVID, we've been, like I said, meeting via Zoom, and we started off really with discussing the importance of what does social distancing mean at the beginning of pandemic. What did that mean, and how do we socially distance, and how do we stay in touch with our friends? And so helping with Zoom and just doing the whole hand washing and all of keeping things clean. So we really talked a lot about that. We have recently discussed vaccinations, how they and their family members can get vaccinated if they want to. The topics discussed are, like I said, decided by them and what they want to hear about. And so then we find speakers to come out and speak with that. In the past, and hopefully again in the future, our DAC groups and our life groups have had projects and met together, which is great, because then you have the young adults and you have the older adults, and they're talking about their past experiences with disabilities and helping each other out. We've done picnics. And we've done an event in Thanksgiving at Thanksmas where our consumers have brought food of their favorite culture or their home culture, and they share it with each other and talk a little bit about what the food is. And so those are really fun. And again, things that we're really missing out on. When I was doing this presentation, I felt like I was doing pre-pandemic, pandemic, post-pandemic, kind of like everybody's doing. 2020 was supposed to be a very big year for all of us in the disability community, because it was the 30th anniversary of the Americans with Disability Act. So we had a lot of things scheduled. We were doing proclamations for the ADA, and we were doing a Knoebels Day at Knoebels Amusement Park, and all of those were postponed to 2021, which now they've been postponed to hopefully 2022. And the reason I'm telling you this is we have a very active Facebook page and website. So I'm hoping after tonight's presentation, you will friend us, and we will be able to keep you updated on our future activities and things that we're doing at our center. Some of our staff and our consumers are very active in our community. I know we talked earlier about, being community is important, and that's kind of how we look at our agency too. One of the things that our many of our staff are involved with, here comes another acronym. It's called our statewide advocacy group, or we call it SWAG. And we worked with our SWAG committee to recently do a virtual conference. It was a 4-day, actually, I believe it ended up being 4-day conference with Centers for Independent Living throughout the Commonwealth of Pennsylvania. And so we had speakers talking about different advocacy, different concerns of people with disabilities. We also started off the conference with Judy Newman, who was a speaker who has been an advocate for the ADA and for people with disabilities for over 30 years. We had a viewing of Crip Camp, which if you have not seen Crip Camp, I would highly encourage you to see it. I believe it's on Netflix. And it talks a lot about the beginning of the ADA and how that came about. We had, which was really exciting for all of us, we actually had Josh Blue as he was the very end of the conference, and it was the day after the final America's Got Talent episode where he did not win. And I do not watch it, but I think he came in second or third. But he was great. If you Josh Blue, and hopefully in the future we're going to have some in-person conferences, and we'd love to get maybe Josh Blue back to come and be at our conference in person. We also with the SWAG group, one of the things that we really are looking into and taking a very active role in is voting. And again, being a good community member means being involved with your community, and voting is very important. We have sessions for our consumers and on our Facebook page of, how to register to vote, where your voting place is, how to make sure that your registration went through so you can vote. If you want to vote by mail, the dates that those need to be, how to do the vote by mail, that's new to all of us in the state. Other states have been voting by mail forever. Pennsylvania, it's new. So, we have the envelope, and one envelope has to go inside the other envelope. So we've done sessions with our consumers on how to make sure that everything was done, that it was signed correctly. But also making sure that consumers look into who's running for what offices, and, voting for the right person for what they want in their lives. We're very active with through the Office of Vocational Rehab with their consumer advocacy group, which their acronym is CAC. And for our counties that we serve, we actually work with 3 different OVR offices. We work with the OVR office in Wilkes-Barre, we work with the one in Allentown, and we work with Reading. We have meetings with our consumers and with different employers throughout the area with the CAC group on who is looking at hiring, and again, how some of those soft skills and how to get someone into an employment. We're active with 2 links, and we serve on their oversight committee. The links are part of and I had to write down what exactly it stood for. It's the Aging Disability Resource Center, the ADRC. You may hear that get thrown around, ADRC/link. It is a group that works with the aging and disability community. And they don't have a mortar and stone. Their theme is kind of no wrong door. So when you call someone who's a link member, again, kind of with our information and referral, that we will get you the information that you're looking for, that when you call the office. Again, we're not experts in every single thing. Nobody can be. So we keep the running record and a list of providers and who to go to get help for anybody who's looking for it. We also provide many of their trainings. We go to this morning, actually, we had a link training on wills and estate planning and powers of attorney, which is very interesting. And so we participate with any trainings that we can for ourselves as providers and for consumers. And we also work on the person-centered counseling, again, where you look at the person is the center of their counseling. The person that you're working with is the person who knows what services they need and what they want as far as services. We have recently completed a memorandum of understanding with our county domestic violence office, which means that we are providing cross-training with our staff and also with the staff of the domestic violence. I do not have the statistic, but I know, unfortunately, people with disabilities face a higher incident of being abused. And so that is something that we are aware of in our office. Everyone in our office has child abuse clearances, FBI clearances, and we go through trainings on child abuse, on abuse of adults for the adult protective make sure that who to call, who to contact, if we see any kind of abuse, that we know who to get in touch with to make sure that people we're working with are being protected and are living safely in their homes. We also have a memorandum of understanding with the Commission on Economic Opportunity, and that is to provide food preparation training to our consumers. Again, put on hold, but we do have an active MOU with them, put on hold until after we're able to get back meeting in person and be able to have them provide healthy, nutritious, quick and easy meals for consumers and for our staff also, because we enjoy them too, on how to prepare meals. We are a member of the Pennsylvania Council for Independent Living, acronym is PICKLE, and it's made up of all of the SIL directors throughout the state. We work together on issues that affect our consumers. Recently, one that we're working on right now is the participants of the home and community-based services and what's going on with their services and how they're being affected. They're looking at, I believe, doing some kind of a rally down in Harrisburg in a couple of weeks. So we don't have all the information on that. But again, that will be on our Facebook and our website. If anyone's interested in traveling to Harrisburg, speaking with legislators, if you're involved with any of the home and community-based service waivers and getting, making sure that those services are continued and that you're getting the hours and the services that you're needed. We used to be we used to provide service coordination for the waiver program. We do not anymore. However, we do help our consumers get involved with the waivers, get enrolled in what they need to do to get the waiver services. A little bit about, I think I said our staff, there's 7 of us, full-time 6, part-time are mostly our van drivers. We do have 2 consumers who speak Spanish, and they're able to help our Spanish-speaking consumers and be able to translate for them. And our Spanish speaking employees have been trying to help the rest of us learn Spanish. I'm not real good at it, but other staff are doing phenomenal at learning Spanish. So it's great to have bilingual staff in our agency. We've provided training to several emergency service providers throughout the area, local firehouses, our 911 centers, our emergency management, training our consumers on what to do in case of an emergency, because you do not want to be preparing for an emergency while the emergency is going on, as we've all have learned in the last year and a half to be prepared. But making sure that there's adequate water supply, making sure that your medication, if you have service animals or even just pets, making sure you have food for all of your animals and what you're going to do in case of emergencies. And emergencies don't have to be global and they don't have to be statewide. We're all from Northeast Pennsylvania. We get a terrible snowstorm or an ice storm. You need to be prepared for that you might be in your home for a few days, and what are you going to do as far as making sure that you're taken care of while you're in your home. We also explain to consumers and again to our own families that you don't want to be meeting your emergency providers while you're in the middle of having an emergency. You get to know, again, people in your community, know who the providers are. Know if you have someone in your home who is using oxygen, make sure that the 911 center, that you're registered with 911, so that they know that your home has oxygen in it or has someone with a disability in that home. So if a call comes through, they know what they're walking into, and that that if there's a fire and there's oxygen being used in that home, that can be very dangerous. And so the emergency providers need to know that ahead of time. Like I said, our staff is very, very involved in our community, and part of the reason is we really like to be involved with our community and we want our consumers to be involved, but it's also easier to make connections with someone if you actually know them. If I now have someone that comes through our door that has epilepsy, I now have Mary I can contact, or someone else at epilepsy, because I've now made a connection with them from being involved this evening. Whereas before this, I didn't have that connection. So it's really important for everybody and people with disabilities to get involved and know who the people are in the community that can help you. Like I said, our office is located in downtown Hazleton. We are actually in the same building as the Hazleton Chamber of Commerce, which is interesting and different, and something that I've had other providers say, you work with your chamber. Well, yeah, a couple of us actually worked at the chamber. And so having that interaction with the business community was very easy for us to do. We actually share our conference room with our chamber. So when they have activities, they're coming into our conference room, and the members of the business community are saying, hey, what is ARCIL? What do they do? What services do they provide? How can we work with them? How do we, October is employment month for people with disabilities. How do we go about helping someone with a disability get employed? So it's been a really great collaboration with our local chamber. We also serve on several boards in our community. I serve myself on the Schuylkill County Local Emergency Planning Committee. So if they're in Schuylkill County, if there's an emergency, and during the pandemic, I was getting calls from the local EMAs probably weekly on, here's the situation, what do we need to do? How do we keep this person safe? What services are available? We're also very active with the local hospital. We serve on several boards at the hospital, and so the hospital is aware of our services and our consumers. And most recently, the Hazleton Art League left where they had been, and they purchased a building across the street from our building. And I was asked to serve on that board, and I jumped right on it because art, we have a lot of consumers of ours that live right in the downtown within a couple blocks of the Art League and our office, and people enjoy doing artwork and being creative, and they put in a full kitchen. So hopefully we'll be able to use the kitchen in the future to do some trainings with our consumers on cooking right there across the street from our building. So it'd be really a great, and whenever they're doing any programs, I'm always like, make sure it's accessible, make sure the lighting is okay, that there's a way to get into the building. So it's really works out very well. The pandemic, I hate bringing it up, but at the beginning of the pandemic, if you're from Luzerne County, Hazleton was the epicenter. We had it was basically like 1 in every 5 residents of Hazleton was getting sick with COVID. So as a community, we were like, we need to do something. We need to make sure that everyone's safe, and how do we take care of this? So we got involved with the school district, again, the chamber of businesses, Can Do, the hospital, the other agencies, our mayors, police force, the state representatives, and our senators, and our county manager. And we were having weekly meetings on what do we need to do to be able to handle getting this pandemic under control. This was new to all of us. So, the city of Hazleton actually had a curfew. So we had to make sure that people knew about the curfew and made sure that it was in Spanish. So our Spanish speaking residents and Spanish residents with disabilities knew what they were and weren't allowed to do during the pandemic, what hours they couldn't, be out on the streets, and if they had to get to a job, that they were able to do that, but, let the police know if they got pulled over that this is, they were going to their employment. One thing about, and luckily numbers are down. So we keep hoping that we keep getting that on the down, and working with everybody in our community to stay safe and what they need to do to keep our numbers and our low in our community. One thing I get all the time is a Center for Independent Living housing? No, it is not. Again, our purpose is to keep people living independently. So we do not provide housing. We do not have housing. We do help our consumers with applying for housing, whether it's applying at the housing authorities, it's applying for rent rebates, any kind of fuel programs, and making sure that they're aware of and know what there is available out there if they need assistance. And we help them with applications for Social Security, for WIC, for, like I said, any of those housing authorities, transportation, anything that someone would need help with, and any kind of assistance. Many of our consumers don't, they can do it, but sometimes there's a question about what they need and how you go about getting a Social Security card, how do you go about getting a birth certificate. So staff is able to help out with consumers with those. We also do at times get equipment donated. So if someone may need a wheelchair or a cane, a shower chair, things like that. If someone is getting rid of them, we will take them. And if a consumer needs them, A lot of times people leaving the hospital might need, before their insurance kicks in to help them with stuff, they may just need for a few days a walker or a wheelchair. And so they contact us to see if we have anything available that they can use. Again, and I was at the beginning, I forgot to mention it, CILs are consumer driven. And they're also all of our boards and all of our employees, 51% of our board and 51% of our employees will have to have a disability. So we really listen to staff and to consumers on what do you want to see us do. A few years, probably about 2 years ago, and we had demonstrations in our office from the Pennsylvania Assistive Technology, and we had a person come in and discuss Alexa. I have Alexa sitting right here, and so I'm surprised she didn't ask me what I wanted.
I don't know that.
There she is. She doesn't know that, and how Alexa can help people with disabilities stay in their homes, and be able to use it. Turn on lights, open up shades, get the weather, all different things that someone can use with that. And that came from consumers. They wanted to hear about it. So we contacted and said, hey, can you come out and tell us about Alexa and what that device was? We had no idea. I now have one in every single room of my house and my family, my mom's house. We all have them all over. And, it really has helped our consumers to be able to, again, live more independently. We've had an example. We had an agency contact a new mom, and she was hearing impaired, and we got devices in the home to help her with smoke detectors. That was a concern. What if there was a fire in the building and she wouldn't know, and she's now a new infant? And so we were able to help find an agency that was able to help her purchase the smoke detectors that flash, so she knew that there was a fire. I know with epilepsy that flashing is not good. So we would make sure if that she had epilepsy, we wouldn't put one of those in there and find something else. But that is something that we do, have people with assistive technology to stay in their homes. And also sometimes we've had consumers, we've had talking smoke detectors. We have that in our building. If there's a fire in our building, our smoke alarm says an emergency has been declared. And, we stared at it for the first 2 days. Like, the first time it did it, we're like, it's talking. We weren't used to that. I know I'm running out of time. Yes.
Yeah, I just have some questions from people that
Sure.
have been asking questions. So
Sure.
you did mention waiver programs, that you don't do that, but you refer them to waiver programs if they need them.
Yes, we would refer to the enrollment broker, and we have that information at the office at where they would need to call to get involved in the waiver.
Okay, and do you have anything that aids in transportation for people to go to the doctor, to doctor's visits?
Yeah, our consumers can use, even though we're not medical transports, they can still use them. We have consumers that use them to go for kidney dialysis. And so if they need to go for medical appointments, they could just call the office. And, most of our transportation is mostly Luzerne County, pretty much southern part into Carbon, Luzerne. The one thing that we do, and again, it has to be scheduled, is we can do we've taken people to the airport in Philly that were going on vacation who use a wheelchair, or if they're going to CHOP, Geisinger, because Geisinger's out of the county. So sometimes emergency medical providers won't go out of county. So we go 2 counties away, we can provide that, but we need, to make sure that we're able to schedule it.
Okay, good. And there was a question, you did mention about housing, but if somebody wanted to, they said that it's risky living in their home, a 2-story home, they have epilepsy. So you would be able to maybe direct them to housing. I know you don't provide it, but you would have the information.
Yes. We have the list of, the housing authorities and getting someone. And that's something I know many people want to stay in their homes, and a 2-story could be a risk. And, we tell people, even when they're buying their first home, will you be able to age out in this home? It sounds silly, 30-year-olds are saying, what do you say? statistically, we're all going to end up with a disability at some point. And, even we train people on, looking at your bathroom and making it accessible, putting in faucets that are easier for somebody to use. Sometimes it's just simple changes like that. But yes, we do have the list of the housing authorities and different programs, Section 8 programs, and helping people with their applications.
And how about like group homes? People wanted to know if there was housing with other people with epilepsy, or that people with epilepsy could live with, like
I know
a
the
group
shared
home.
and also the shared living program. I know that
Yes.
was being really discussed again pre-pandemic pretty heavily. I don't know where that has gone right now.
I know Wayne County is big on that.
Yes,
The
and
shared housing.
Luzerne County was kind of starting it up, and they again, that was kind of put on. It's hard to get those programs started up when people aren't meeting in person, and but I don't know of any specific group homes, but that's something that we could look into and see if there's anything.
And I think a lot of our people will probably be contacting you, the waivers, because they do want to stay at home, but they need an aide, maybe that would come in for so many hours to help them with their meals, because people with epilepsy can't really be around stoves or ovens or things like that. So, and bathing, they shouldn't be alone when they take a shower. I mean, not that you need somebody washing them, but just somebody there in case they have a seizure and they fall, they don't drown in a couple inches of water. So those would be all handled through the waivers. And is that
Right?
Okay, so you could direct them to that.
Absolutely.
Okay, great.
And it's funny when you're saying about that, like, it's always good for everybody. I live on my own, so I, make sure, again, before showers or before something like that, I make sure somebody knows, because if they don't hear from somebody, make sure you find out what's going on. Again, taking care of each other, accidents can happen to anybody, but, absolutely, like you said, somebody with epilepsy showering, showers are dangerous. I'm always yelling at my family members. Do you know how
Little
dangerous
things that you don't think of,
Right.
taking something out of a microwave that's hot if you're having a seizure is suddenly dangerous. Showers,
absolutely.
like I said, inches of water, you could drown. So that's the things that, little things, like you said, you don't realize until it happens.
Mhm.
So, but thank you for sharing. You're a wealth of knowledge.
Oh,
I do have to
thank
say, tons of knowledge, and we appreciate that.
Sure. Like I said,
Appreciate your
call our office, go on our Facebook page. Sometimes just throwing out questions with each other and talking it through gets answers solved too.
great. We appreciate your time and your
Thank you.
talent.
Thank you very much.
You. Thanks. Okay, so now we're going to wrap up with some announcements. There's a Philly educational conference on October 30th. It's from 9 until 1, and you can register at that link. And they'll have information different than ours, but a lot more. So it's worth marking in on your calendars and checking into that. We do have our Strikeout Epilepsy Bowl-a-thon Sunday, November 7th at Chaco's in Wilkes-Barre from 3 till 5. $15 to bowl. You get your shoes, you get pizza, drinks. We're going to have great raffle baskets, and you get to meet a great bunch of people, families that are dealing with epilepsy. So you'll have kindred spirits. So you can contact me, either call or email me. Let me know if you have a team, or if you just want to bowl with somebody, we can put you on a team. Or if you just want to come out and hang out, you're more than welcome. And we have educational webinars. We have a pediatric surgery webinar coming up. It's a series, November 1st, 9th, 15th, 29th. It's from 5:30 to 6:30. And the topics will be on the registration. It's for pediatric surgery. So that's the information there. And we have a Spanish education wellness webinar, November 2nd from 6 to 7 p.m. Registration is there. That should be very good too. And November is Epilepsy Awareness Month. It's National Epilepsy Awareness Month, and we will be tying purple bows around courthouses, well, in my 6 counties in the Northeast, but all through Eastern PA. So tie purple ribbons through your community, show your support. We'll be running articles in newspapers and be on TV, PA Live up here. You'll hear radio spots. We're talking about November Epilepsy Awareness Month. So just watch our Facebook because we'll have a lot of activities coming up. We want to know everybody to know that epilepsy is very prevalent. Many people have it, and we want them to show their support and love. So if you would take a few minutes and do a little evaluation here, this will help us gear for further programs. There's 4 questions. I want to thank everybody for attending. I want to once again thank Dr. Mercuri, and I want to thank Denise Corcoran for all their knowledge and their time, and all of our pharmaceutical reps that made this possible. Our behind the scenes person, Rena Laughlin and Missy Dalloway. And all of you for attending and giving your time. We really appreciate it. So stay in touch, stay healthy. Let us know if you need anything. That's what we're here for. Okay, everyone, have a good night and a great week ahead. Take care.